question is that whether any patient who comes to you for keratoconus, with keratoconus, should we cross-link all the patients? The answer is with Dr. Vijay Sharma, and he will be discussing this question, that whether all keratoconic corneas should be cross-linked or we have to select patients to cross-link. Dr. Vijay, please.
Thank you, sir. So, my topic is, should all keratoconic corneas be cross-linked? Now, starting with a historical perspective about collagen cross-linking, it was Wolensek et al. In 2003 who were working at Technical University of Dresden, where they first time described the collagen cross-linking. That's why the conventional protocol came to be known as Dresden protocol. Uh, Basically, riboflavin saturated cornea is irradiated with the ultraviolet A radiation of 370 nanometer, and it increases the cross linking between the adjacent collagen fibrils, which increases the biomechanical strength of the cornea, and also it stops the progression of corneal ectasia. So, if we see what are the indications at present, so the indications are can be divided into ectasias and non-ectasias. Ectasias include primary ectasias such as keratoconus and pellucid marginal degenerations, and secondary ectasias such as post-lacy ectasia. In non-ectatic disorder, the collagen cross-linking is being done for infectious keratitis, as in PAC-CXL, bullous keratopathy, chemical injuries, and even Terrien marginal degenerations. In keratoconus, how we progress, how we go ahead and decide for keratoconus collagen cross linking. In adults, it's recommended that you should document the progression for the keratoconus, whereas in children usually the progression is very fast and you do not wait, and you can plan for collagen cross linking without waiting or documenting for progression. If the corneal thickness is more than 400, you go ahead with the isosmolar collagen cross linking. If corneal thickness is between 330 to 400 micron, you can go ahead with a hyposmolar collagen cross linking. Also, you can, if you want to improve the visual acuity in addition by use of eximers, then you can go ahead with a PRK and CXL as in topo-guided removal of epithelium in keratoconus. And also you can follow up you can go ahead with the PTK and CXL as in keratin protocol. You can also combine CXL with the intracorneal ring segments as well as eye tract in addition to this. And also you can go ahead with the customized cross-linking. So these are the various protocols at present where the collagen cross-linking you can do in keratoconus. Another important criteria is we have discussed the corneal thickness and age. Another important thing is the progression, as we have to document in the adults. Now, how do you go ahead with the what are the various criteria? Now, criteria have been changing over a period of time. In 2003, Dresden, they took as an increase of K max by more than 1 diopter, and patient self-reporting deterioration of visual acuity and also need of contact lens fitting more than once in 2 years. Whereas then they kept on changing slightly, and last recommended was Gomes et al. In 2015, who said that progressive steepening of the anterior corneal surface, progressive steepening of the posterior corneal surface, and progressive thinning. And they did not give any specific values because these values are specific to specific instruments. So, in addition, there are some cases where perceived risk of progression is high, then documentation may not be required, and you can go ahead straight away with the collagen cross-linking in those cases. I'll not go in detail in the protocols because these will be covered in subsequent lectures. There you'll see which one is better, and should we go for a standard or a accelerated protocol? Do we have any role of supplemental oxygen or pulsing of the UV radiations? How will that affect the collagen cross-linking? Also, the iontophoresis. Iontophoresis, I have no first-hand experience as such, but what has been described is single cycle or a double cycle CXL iontophoresis can be done. In single cycle, electrode is placed over the cornea and a forehead, and 5 milliampere per 5 minutes is the current that is passed. It increases the penetration of riboflavin into cornea with epithelium on, and in double cycle it is a 10 milliampere per 10 minute which is passed, and then collagen cross linking can be done. These are some of the contraindications if the patient is having any herpetic ocular infection, if there are any concurrent ocular infections or neurotrophic keratitis, poor epithelial wound healing, severe dry eyes, autoimmune disorders in pregnancy. You should avoid doing cross-linking, or you should be careful, take all the precautions. What if collagen cross-linking fails? Any criteria for repeat collagen cross-linking? There are few studies which have been published. If the previous collagen cross-linking has been done at least 6 months earlier, and there is increase of Kmax by more than 1 diopter, and the increase of manifest cylinder by more than 1 diopter, that has been taken in most of these studies as a criteria for progression of keratoconus after collagen cross-linking. And usually these are the children who are having the allergic conjunctivitis, frequent eye rubbing, and pre-op Kmax value more than 58 diopters, and paracentral cone, who are more likely to require the repeat collagen cross-linking. And when to do which technique, still there is no consensus as such, but you can take your preferred technique in these. What if there is no documented progression? As you know, if the other eye has healed hydrops and this eye has a keratoconus, you should go ahead with a collagen cross-linking in this eye to increase the biomechanical strength. Similarly, if the pachymetry is approaching your cutoff values, and then you can go ahead with the cross-linking without documenting the progression in these adult patients. In this, you can see the thinness package is around 355. So you should not wait for 6 months and wait for the corneal thickness to become even lower, and then it goes out of the your collagen cross-linking perspective. Now, in this case, you can still wait. There is sufficient time, so documentation can be done. So, thank you.